Hello everyone. Today's video covers 20 hematology MCQs and 10 spotters. First question is, which organ is the primary site of hematopoiesis in the fetus before mid-pregnancy? Now here the important word is before mid-pregnancy. So after the 4th month of gestation, okay, it is the bone marrow that takes over, okay, after the 4th month of gestation, and the initial up to 10 to 12 weeks of gestation, it is the yolk sac that takes care of the hematopoiesis, and up to 20, after these 12 weeks, up to 20 to 24 weeks of gestation, it is the liver, and finally after the 4th month, it is the bone marrow. So the question clearly states before mid pregnancy, so we have to mark this answer as liver. This is the primary site of hematopoiesis in the fetus before mid pregnancy. After 4th month, it's the bone marrow. All are true regarding fetal RBCs except elevated 2,3 DPG, decreased carbonic anhydrase activity, decreased lifespan, and high RBC volume. Okay, so all are true. Decreased lifespan, yes, regarding fetal RBCs, this is true. High RBC volume, yes, this is also true. Decreased carbonic anhydrase activity, this is also true. Elevated 2,3 DPG is false because fetal RBCs have less 2,3 DPG. Okay, so the answer to this question is A. When does switchover from fetal to adult hemoglobin synthesis begin? Okay, the answer to this question is 36 weeks gestation. Switchover from fetal to adult hemoglobin synthesis. Fourth one is a case scenario. A 5-year-old girl was brought with history of progressively increasing pallor since birth and with hepatosplenomegaly, which is the most relevant test to reach the diagnosis. Now here it mentions since birth. That means this is not an acute scenario. There is hepatosplenomegaly. The girl is 5-year-old now, and it has been progressively increasing. Now here in this scenario, first of all, what are we suspecting? Okay, increasing pallor with hepatosplenomegaly, we are suspecting some hemoglobinopathy or hemolytic anemia like situation, for which the diagnosis of which will demand an HB electrophoresis. Now peripheral blood smear, this is usually helpful if the presentation is very acute, right? Because if there is worsening pallor and there is hepatosplenomegaly, then malignancy is something we are worried about. So in the acute setting, peripheral blood smear will be useful. Osmotic fragility test, this is for hereditary spherocytosis. So this actually does not have a role when there is progressively increasing pallor and hepatosplenomegaly. These children may present with a splenomegaly and jaundice. Okay, but this particular scenario fits into HB, hemoglobinopathy, right? So HB electrophoresis will be the test of choice to reach a diagnosis. Bone marrow examination is an invasive test. So, and in this particular scenario, first we will go ahead with the most likely diagnosis, since this etiology is going on, this pathology is going on since birth. So HB electrophoresis, and most likely diagnosis we are expecting will be thalassemia. Macrocytic anemia is due to all except. So we all know that thiamine deficiency, orotic aciduria, liver disease, all these can cause macrocytic anemia. Copper deficiency is not a cause of macrocytic anemia. Beta thalassemia, most common genetic mutation is point mutation in beta thalassemia. Defect in thalassemia is in the hemoglobin synthesis. We all know this. Defect in thalassemia is in hemoglobin synthesis. In beta thalassemia trait, what is true? There is increased HbF, increased HbA2, microcytosis or severe anemia. Now it is trait, so they will not have severe anemia. They'll have anemia but not severe. Microcytosis, yes. Increased HbA2, yes. Increased HbF, no. So increased HbA2 is the answer in beta thalassemia trait. HbA2 concentration in thalassemia trait is more than 3.5. 7 months old infant has 6% or 6 gram per deciliter of hemoglobin, anemia and peripheral blood picture showing target cells. Similar history in family members. Which test should be done for diagnosis? Now remember, this is a 7-month-old infant, 6 gram HB, anemia and target cells on smear, and with a family history that is positive. Again, this is pointing towards thalassemia. So HB electrophoresis is the test of choice. Not true about beta thalassemia major. Splenomegaly, target cells on peripheral smear, microcytic hypochromic anemia and increased osmotic fragility test. So thalassemia major will have splenomegaly, will have target cells, microcytic hypochromic anemia, yes. Increased osmotic fragility, no, that is seen in hereditary spherocytosis. Nesterov test is a screening test for the use of beta thalassemia. Screening test for beta thal. Bart's hydrops fetalis is lethal because HB Barts cannot bind to oxygen. The excess alpha globin forms insoluble precipitate. HB Barts cannot release oxygen to fetal tissues and microcytic red cells become trapped. Okay. So HB Barts cannot release oxygen to fetal tissues, and that is why Bart's hydrops fetalis is lethal. Okay, this is the right answer. A baby died soon after birth, had edema all over body and hepatosplenomegaly. Most likely diagnosis is, now remember that they have mentioned died soon after birth and had edema or hydrops, okay, with hepatosplenomegaly. Most likely diagnosis among these four options, beta thal, alpha thal, hereditary spherocytosis and ABO incompatibility. The most likely answer here is alpha thal, because severe alpha thalassemia, this is incompatible with life and the baby will die soon after birth. Mutation leading to sickle cell anemia is point mutation. Commonest presentation of sickle cell anemia among the options: bone pain, priapism, fever, splenomegaly. What is the most common presentation? Bone pain. Bone pain is the most common presentation in sickle cell anemia. Right? Iron is absorbed from duodenum, stomach, ileum or jejunum. So it's absorbed from duodenum and proximal part of the jejunum. But if both the options are given, you need to mark duodenum. First change of improvement noted after iron therapy is initiated: decreased irritability, reticulocytosis, increase in serum iron levels and replenishment of iron stores. The first one is a change in the symptom. Decreased irritability is the first change of improvement noted after the iron therapy is initiated. The other three are all lab findings and are seen later. But decreased irritability is the first change of improvement. The earliest indicator of response after starting iron in 5-year-old girl with iron deficiency, the earliest indicator is increased reticulocyte count, which happens on the second or third day. Increased hemoglobin and ferritin and serum iron, all that happens later. On the second or third day, there is increase in reticulocyte count that starts. Hemoglobin starts improving by 4 to 6 weeks, and then the stores, ferritin and serum iron, those start replenishing. Megaloblastic anemia develops in vitamin C deficiency, thalassemia, sideroblastic anemia or infants fed with goat milk. Now thalassemia and sideroblastic anemia, These are both microcytic forms of anemia. Infants fed with goat milk is deficient in folate, and therefore predominant feeding with goat milk can lead to megaloblastic anemia in these infants. Now, image based questions. What is this first image showing? This is showing bite cells. Like you can see, the arrows are pointing towards bite cells, and that is because of G6PD deficiency. What is this image showing? This image is showing prickle cells, right? You can see over here clearly prickle cells, and this is seen in pyruvate kinase deficiency, right? Pyruvate kinase deficiency. What is this? This is helmet cell. Okay, this is seen in thrombotic microangiopathy or microangiopathic hemolytic anemia, HUS. Okay, helmet cells, schistocytes are seen in HUS or thrombotic microangiopathy. These are what? These are sickle cells, and they are seen in sickle cell anemia. Okay, sickle shaped RBCs. What are these? These are echinocytes. Okay, and they are seen in uremia. Okay, echinocytes are seen in uremia. What are these? These are teardrop cells. These are seen in which disorder? They may be seen in thalassemia or in bone marrow infiltration. What are these? These are target cells. Okay, you can see the bullseye appearance. Target cells, these can be seen in iron deficiency anemia and thalassemia. Target cells. What are these? These are hypersegmented neutrophils. Hypersegmented neutrophils, like you can see in this picture, and you can see the RBCs enlarged. So this is seen in megaloblastic anemia, right? B12 and folate deficiency, megaloblastic anemia. What are these? These are spherocytes, and they are seen in hereditary spherocytosis. And what is this? These are microcytic hypochromic RBCs. You can see pallor, severe pallor over here in the RBCs, central pallor. This is microcytic hypochromic anemia and typically seen in iron deficiency anemia, this blood picture. Okay, so that's all for today, guys. Stay tuned for next video.